I'll try to speak in English so you can understand me easy. First of all, I'd like to thank you, Geeta and Ricardo, for coming to Porto Alegre. I'm not sure everyone is aware that you are part of the contribution. You have contributed a lot to be here and talk to us in this opportunity. I'm aware of cognitive flaws and the works in cognitive psychology of Tversky and his colleagues, and a lot of Dan Early, and even some mathematicians as Gridinsky, who made works on some options we make and their irrationality. In this, I think in this September issue of the American Journal of Forensic Medicine, it was published an article about diagnostic errors in Turkey. They have used autopsies as gold standard for checking diagnosis, and I have shown that mainly in the first 24 hours of admission, patients who die in the first 24 hours, they have about 64.7% diagnosis error in those patients. This rate decreases along the stay of the patient in the hospital, so we can make more exercises, more exams, and maybe can change our diagnosis. But even in the end, about 23 days of hospital stay, they have even almost 20% diagnosis error. And I am a former medical examiner, and today I work with medical malpractice. And we are making some advocacy on autopsies for checking as the gold standard and for checking and controlling quality in hospital. How do you, what instruments you use in your MMR, in your morbidity and mortality rounds to check on your diagnostic errors? Autopsy, RCA, what kind of instruments are you using to control your quality there and to give a feedback for the medical team?
What great questions. So multiple things. So Pat Crosscarry is one of the leaders in this field, and I actually got a chance to work with him just a few weeks ago because there is a National Diagnostic Error Conference, and we had the fourth one this past October. So, of course, if you get a chance to read any of his work, it's so fascinating. I would really recommend it. So diagnostic errors is such a new field, and it's very hard to study. So every time we meet at the conference, no one really knows what to do in terms of exactly how to quantify what's going on. A couple of things, though, that we do at Texas Children's that I think is helpful is that if a patient is admitted from the emergency room and has a code or has what's called an RRT, a rapid response, where it's before a code, but the child is identified too sick to be on the regular floor, a process is in place, a quality process, where that case is reviewed. So that's not necessarily diagnostic error, but it's more that something about what happened to the patient in the first 24 hours didn't go as expected. Then somebody from the ER says why, and it's looked at from the quality perspective. And then now in Canada with Dr. Crosscarry, he's also an ER physician. So in his hospital system, if he sends a patient home, for example, with heartburn or with reflux, and the patient comes back with a heart attack, he and his boss will actually get a letter. So he has a feedback system, but I have not seen that kind of sophisticated feedback system like you're mentioning at Texas Children's or in most of the hospitals where we talk about diagnostic error. So I think there's a lot of work to be done in terms of first figuring out how much is going on, the impact of diagnostic error in general, and then the second part is what to do about it. Because I find even when we talk about diagnostic error, it's a new concept. So one of the issues is that if physicians don't know much about diagnostic error in the first place, it's hard then to measure it and to be aware of what's going on. So I think where we are in the field of diagnostic error is still defining what's going on, raising awareness, and trying to figure out how to do more research. So for example, the data from the malpractice is, I'm not saying that that's the right way to measure it. It's what we have. Autopsy is the gold standard. However, especially in pediatrics, luckily very few patients die in the U.S. and parents don't like to say okay to autopsy. So we have to get it at different ways.